And welcome to those here in the conference room and those online. It's my great pleasure to welcome you to the Florence Mahoney Lecture and our lecturer, Jen Manley, who's going to be talking about policies to PTAO. We'll introduce her in a little more detail later, but first some housekeeping topics. For those of you who are looking for CME credit, this is it. 50124 is the code, except for those in the room where reception isn't good enough to allow you to get credit, but for the rest of you, please do. In terms of feedback, for those online, use the send live feedback button on the videocast, and at the end of the meeting, we will read and get responses from Jen to your answers and for your questions. And for those here in the room, we have a couple of microphones that will be live at the end as well. With that housekeeping out of the way, let me just introduce first the Florence Mahoney Lectures, named, obviously, for Florence Mahoney, who is an outstanding woman who, along with Mary Lasker, was really responsible for many of the innovations and congressional actions that established components of NIH, notably NIA. I had the great pleasure for many years of knowing her and meeting with her at her home in Georgetown, and it was always into the advanced age over 100 when we last were met. She died, I think, at the age of 103. But to the end, she was vital, interested in these lectures. And she said, I don't want any nonsense. I want you to have great speakers who are talking about real hard science. That's what I want. And we would discuss who was coming up next. She would approve, and she would be thrilled, of course, with Jennifer being here now. The other anniversary we're marking now is the 50th anniversary of NIA since its inception. And so we'll count this and Jen's presence as an important part of that celebration. So now just to briefly introduce Jennifer to you. She did her undergraduate work at UC Berkeley and then her graduate work at UC San Diego before going to Columbia, where she rose to the rank of professor that she now occupies in the area of neuropsychology. She's done outstanding group, a rare accomplishment in linking social, environmental determinants to clinical outcomes and to the biologic biomarkers in between, all captured in her title here, Policies to PTAO. Social and structural drivers of Alzheimer's disease, opportunities for brain health and justice. Her career has been prolific, exemplary, and notable for many aspects, but for one among the many, the way in which she has made community engagement work and demonstrated the critical importance of engagement with communities for the kind of research that needs to be done. So she taught us all lessons. She served on our advisory council and helped us there. And now she's here to impart some of her wisdom to all of you. So Jen, it's a pleasure to have you here, and welcome.
Thank you so much, Richard. It really is an honor to be with you today. And I did read the New York Times obituary for Florence Mahoney. It's very interesting for many reasons, and you said some of them, which was that she was a constant advocate. And the other thing was that she said that she didn't bother, she needed something, she just went straight to the top. So that meant, going to the president, whoever it was at the time. And apparently they would groan when they saw her because they knew she was going to be asking for more funding for the National Institutes of Health and specifically the National Institutes on Aging. So happy anniversary, and I am extremely proud and honored to be here. I am going to thank the group of people that I work with at Columbia University. They are really the gears that make everything work and the funding that supports the work that I do. And other than these NIH grants, I don't have any disclosures. So first, I'm going to remind all of you in the room, because I recognize many of you, I know that I don't have to do this in detail, but I'm going to remind you of the scope of the challenge that we're facing. This is a line graph that shows the increase in millions of people with dementia in low and middle income countries compared to high income countries from 2013 to 2050. And so what we are estimating is that by 2025, more than 70% of the global dementia population will live in low and middle income countries. And right now, dementia is the 5th leading cause of death worldwide. And by 2028, the cost of dementia care, that includes formal medical care and also informal caregiving costs, will be more than $2 trillion worldwide. So we must intervene to reduce the current and future burden of dementia worldwide. And what that means is that we need to identify modifiable factors, modifiable risk factors, modifiable resilience factors. And so this figure, which all of you have seen 1,000 times because it's so compelling, from the Livingston systematic review in Lancet in 2020, essentially carries us through the life course, and the size of each of these circles that represents a modifiable risk factor is determined based on how common that risk factor is and also its strength of impact on dementia risk. And that percentage that you see within each circle is the percent reduction in dementia prevalence if the risk factor is eliminated. So by the time you get to the end, you find that around 40% of dementia is considered modifiable using the best evidence that they had at the time for this review. And that is a tremendous amount that we can do to preserve cognitive health. And because modifiable forces, like the ones that are listed here, are the cause of inequalities in cognitive impairment and dementia, this also suggests there are tremendous opportunities to narrow disparities. But these data are based almost entirely on data from white people in high-income countries. So I always show this because I love what Rock Nyanogo did, which is to use U.S. representative data on prevalence estimates of those modifiable risk factors. He used the BRFIS to get those data, and then again graphed the relative strength of the association of each of those risk factors with dementia in each racial and ethnic group that he had information for. And what he found was that the proportion of Alzheimer's disease and related dementias associated with the top modifiable risk factors was relatively higher among men versus women, and among Black individuals, American Indian and Alaska Native individuals, and Hispanic individuals compared with Asians and whites. So this, I think, underscores the importance of nationally representative data where the sampling allows for group comparisons, and also to inform, optimal prevention efforts in groups that are experience higher burden of cognitive impairment and dementia. So what is the best way for us to examine these modifiable risk and resilience factors and to develop strategies for narrowing disparities, with a goal to extend, hopefully, to extend cognitive life expectancy for everyone and minimize disability due to cognitive impairment? It really demands a life course perspective, which all of you at NIA are deeply familiar with. But I think it's relatively new, a life course perspective, for people who study Alzheimer's disease. So I'm going to bring you through one here that sort of guides my work. And we're going to start with proximal causes of cognitive impairment and dementia. Alzheimer's disease pathology and vascular dementia are probably the most common dementia subtypes, or the pathology subtypes in the United States. And you can see that I'm starting in the brain and leading to cognitive function and dementia on the right side of this process. And then we have things that can be seen in the clinic when people show up at the clinic, both risk and resilience factors. And I wonder if my resilience factors are going to show up at some point, but they're in here, essentially pointing out that there are not just factors that relate to deficit in one's environment, but also factors that relate to strengths. The things that we can see in the here and now, like diseases that increase risk for Alzheimer's pathology and cognitive impairment, are are influenced by these social determinants of health. I like to talk about resilience factors because they interact with risk factors. Laura Zahodny actually did a really nice study where she showed that even though Black older adults reported greater stress exposure than white older adults, Black older adults appraised those stressors as less upsetting than whites. And so even though stress appraisal didn't really moderate those links between stress, exposure, and memory, appraising stressors as less upsetting was independently associated with better memory in Black adults. And so I'm pointing out here, you can see where race and ethnicity is in my model. Race and ethnicity is a downstream factor. The classifications of race and ethnicity in these models connote that those classifications are made. They are historical, political, economic, and cultural. And I saw a tweet the other day from Dedrick Williams who said, racism makes the idea of race possible. And I like how that's phrased. And that's what I'm trying to connote with the arrows going into the race box here. So structural and social determinants of health can buffer or exacerbate risk. What you can see at the core of this life course model is historical and contemporary systems of oppression, discriminatory beliefs, and also the institutional power that comes along with those beliefs. I added a new one for this talk. I'm going to type one more, which is militaristic hyper-policing, because I think that that's one form of institutional power that can get under the skin in neighborhoods for individuals and targets people from minoritized groups. The other thing to keep in mind is that our experiences of these social forces and these structural forces really changes depending on when we're here on Earth. Birth year is a factor, and that's actually one of the wonderful design aspects of studies like the health and retirement study, where we can look at different birth years and different waves over time. Okay, and then the red arrows are really connoting that risk and resilience factors and social determinants across the life course could play a part in cognitive reserve or cognitive resilience. So that gap between the level of pathology in the brain and the experience of cognitive dysfunction. So the first question, once we decide we want to interrogate this life course model of social and structural factors as they relate to ADRD, is who should we study? And I'm going to talk about that for a bit. So this is a map. It's a little bit older, but it's still probably roughly accurate, that shows the overlap between county-level prevalence of Alzheimer's disease and NIA-funded ADRD centers. So you can see that there are some big location gaps, especially in the Deep South. So looking for collaborators in the Deep South that are Alzheimer's disease research centers is actually very difficult. So I think that in part who we study depends on where we're at. And we need to be at those places where people with Alzheimer's disease are. And that's essentially what I'm trying to say with this graph. The other thing that comes up is selection bias. And we were just chatting before the talk about the recent study that was based in NAC, looking at people with 2 copies of the ApoE4 allele. And it just immediately made me think of this paper by Miguel Arce, who compared the demographics of people in the NAC study with the demographics of people in the health and retirement study, which is population-based. And this is a first step in then being able to transport findings that you have shown in NAC to a population-based cohort. And you do that by creating weights for each individual in the HRS, depending on how they are represented weights for people in NAC, depending on how they're represented in the HRS. So essentially, this is first step is looking at covariate balance, and then those dashed lines are the standard mean difference between the NAC and the health and retirement study. And what Miguel found was that NAC participants are older, they have more schooling, they have worse subjective memory, and worse hearing, but they endorsed fewer depressive symptoms compared to HRS participants. And those differences in age, depressive symptoms, and hearing difficulties were larger among the Latinx and non-Latinx Black participants compared to the non-Latinx white participants. So this is just to say, and it's probably too small for those of you in the room, hopefully not online, but you can see in one of the tables that Miguel has in the paper, that the overall representation of Black and Latinx people in NAC is pretty good. It's almost essentially matching that of the HRS. But just because the composition of a sample may match the national population, it doesn't mean that those participants are representative of the national population. And it's especially problematic when we have those interactions between the demographic factors and race ethnicity, if we're going to be making conclusions about racial and ethnic differences. And this comes into play with trials as well. So this is a paper by Casey Dieters, who looked at the A4 trial, and this table is buried in the supplement, but all of you should look at it. And it shows that she traces Black volunteers for the A4 trial through the screening process. And at the first stage, they had to undergo cognitive testing and a CDR. So Black participants in the A4 trial were more likely than white participants to have CDR scores above 0, which was a requirement to have a CDR score of 0 for the A4. And they also had lower mini-mental and logical memory scores than white participants, and they were more likely to be screened out at that first stage than the white participants. And then at the second stage, the people who got through, regardless of race, did an amyloid scan. And if they weren't amyloid positive, they could not be a part of the trial. And as it turns out, Black and Asian participants were more likely to be screened out at that stage as well. So they were less likely to have amyloid at that second stage. And so, there's one piece of evidence that, up until last week, I was saying, well, this is because you're screening out people based on the cognitive test, which is biased, and then you are, trying to look for amyloid, but you've already screened out all the Black people with amyloid because you made them perform much better than the population of Black people does on these biased tests. And so that made sense to me until I looked at this study, which came out in April. In this study, they pooled 4 different trials that the first screening method was basically plasma A-beta levels. If you had a high plasma A-beta level, then you could go on and get your PET scan. And this is Doris Molina Henry, and she's working with Josh Grill. I think he's the senior author on this paper. But essentially, the figure shows the proportion of plasma biomarker eligible people by race and ethnic group. And the results were actually very similar to Casey's results, that people of Hispanic ethnicity or Black or Asian race were less likely to qualify for the treatments based on that plasma biomarker before they even did any cognitive testing. And but the underlying reason that the author cited for this was that these groups have lower rates of biomarker-confirmed Alzheimer's disease. And so this is among several now results coming out from multiple cohorts, and people are starting to suggest that the diagnosis of Alzheimer's disease should rely on maybe different cut points by race in terms of biomarkers. And that different therapies will have to be developed for non-white people. But I guess I want to know whether selection bias, could affect these results as well. So I'm going to bring you now into some studies that I've been working on for a really long time to kind of, interrogate this. So this is the YCAP study, the Washington Heights, Hamilton Heights, Inwood Columbia Aging Project. It's been going on since 1992. And it's a cohort of people who are Medicare eligible who live in the census tracts around the Columbia Medical Center in northern Manhattan. Over 6,500 people have participated, and we visit them in their home to do a workup. So they get neuropsych testing, they get medical evaluation, blood. Many of them come into the medical center to get MRI. And census records show us that this cohort is representative of older adults who live in these neighborhoods. So we are right on in terms of race, ethnicity, in terms of education, in terms of language. All of our, the people on our staff are bilingual in Spanish and English, and all of the measures have been adapted in Spanish and English and used for many years, and it's a longitudinal cohort. And when plasma biomarkers first came along, they were sent out for analysis, and the question could be asked first, how well can these blood-based plasma biomarkers distinguish between those with and without a clinical diagnosis of dementia in YCAP? And also, are there racial and ethnic differences in the levels of these plasma biomarkers? So first thing to tell you is that the levels of amyloid, tau, and NFL were not reliably different in YCAP across race ethnicity. So we are not replicating the Molina-Henry paper. And the biomarker, just for you to log, the biomarker that best distinguished between those who had a clinical diagnosis of Alzheimer's disease versus normal cognition was p-tau 217 in this study. But you can see from those area under the curve, the prediction for each biomarker was certainly not as good as you will find in clinic-based samples. This is a community-based sample. But all markers taken together had a, I guess, relatively decent area under the curve. And here's another chapter in the Who to Study saga with a biomarker, plasma biomarker plot. After 25 years of work in YCAP, we realized that starting research participation at age 65 in this cohort was way too late. That a lot of the action that had to do with risk and resilience had already happened in midlife, and we were already seeing very high levels of especially cerebrovascular disease on brain scans. And so we were interested in catching those mechanisms early and studying critical periods in the course of Alzheimer's disease among Black and Latinx people, in part because of accelerated aging and also differential survival. So the differences at age, racial and ethnic differences at age 65 are really as wide as they're going to get because of differential survival. The second reason why we wanted to start another study was that fewer large-scale cohort studies had prospectively collected data from both parents and offspring generations, and most intergenerational research on Alzheimer's disease to date had been mostly white cohorts, well-educated cohorts. So we were able to get funding for the offspring cohort, and so far we've recruited about 2,100 adult children of the YCAP parents and are studying them longitudinally. We have done plasma biomarker levels among these offspring, and their mean age is about 55. There are no racial and ethnic differences in amyloid, in p-tau, in NFL, or GFAP. And so, again, we're not replicating the papers that are coming out from convenience samples or clinic-based cohorts with respect to racial and ethnic differences. So it is to sum up, the results in convenience samples do not generalize to population samples. I should say what's not published yet are results from REGARDS, results from the Health and Retirement Study, results from the High School and Beyond Study that are basically essentially the same as what I'm showing you with the YCAP and offspring. No differences across groups. And so thus far, I think that those clinic-based studies could lead to misleading conclusions about modifiable risk and resilience factors for Alzheimer's disease and related dementias. And I wanted to point out here one of my favorite new studies, which is the ACHIEVE trial, the hearing randomization trial, where they really only found the results in the community-based cohort. And so, generalization is that there couldn't be a better example of how important it is to have a representative cohort. So let's move on now. We talked about who we're going to study. Let's move on to what should we measure. Early in my career, I was really concerned with cognitive test bias. And some measures, like language-based measures or reasoning-based measures, are more biased than measures that, like a wordless learning task for people with low literacy, for people with a different educational background, with people with different cultural backgrounds than those who the tests were originally developed and normed on. I found in my research that first there were these differences across domains. There's some domains that we could really rely on, some tests we could really rely on to be accurate reflections of cognition regardless of literacy level, regardless of educational and cultural background. And some were just, basically not helpful at all in making a distinction between cognitive impairment, real cognitive impairment, and normal cognition, normal aging. I also found that longitudinal assessment or change over time as an outcome in these studies was much more less biased than intercept or performance at any one cross section. Tremendous advancements have happened in neuropsych assessment since I started out. And in addition to adaptive cognitive measurement systems like NIH Toolbox, we have more data on these traditional tasks that have been adapted across context, language, and harmonized across cohorts. Some of them have been harmonized intentionally, like the let me see if I can get this right, the Harmonized Cognitive Assessment Protocol. I almost did a John King there because he calls it something else. And also the harmonization might be unplanned, like a recent effort to harmonize all of the studies involved in the C4R collaborative cohort. So what does it really mean to harmonize? I'm showing you some of these starting steps here, which is to identify universal domains of cognition that are important to cognition in aging, and then represent those with multiple different measures. And that's kind of what's clarified in these factor analyses, in these confirmatory factor analyses that have occurred in both Halsey, I'm showing you on the left with Lindsay Kobayashi, and also that's a study in South Africa that's one of the HCAP Global Network studies, and the US HCAP, that's Rich Jones's paper there on the right. So I think it's been a major achievement to find these batteries of tests that can be adapted across settings, across like drastically different settings to measure these different domains. But I do just want to remind you that we need to do our due diligence, especially when we harmonize, to figure out, to systematically test whether our measures are invariant across groups and subgroups, across race, ethnicity, language, sex, gender, education, and also over repeated measures. And so throughout my career, my concern about bias in testing has really evolved to, we need to do this step. We need to look for invariance across these different tests. And what Justina Avila-Rieger found in the YCAP study was that when we did that, across race, ethnicity, age, sex, gender, and time of measurement, meaning first visit, second visit, and so on, that some of our tests needed to get thrown out because they had because they did not have invariance, metric invariance across these different groups. And so if we were to create a factor score that included those tests, it would introduce bias across different groups. And so now these are the tools, these are the psychometric tools that we have to address these measurement problems. But let me, let's say you're in the audience and you're like, Jen, I don't care about cognitive testing. I just want to know who has dementia and who has MCI. Those classifications, they're not biased because they have, yes, they have a cognitive component, but they also have a functional component, and that's real. And so they're too messy. Continuous measures of cognition are too messy. Give me the adjudicated dementia status. And that's what Miguel did when he looked at, in the YCAP cohort, whether illiterate people are at higher risk for incident cases of Alzheimer's disease compared to literate people. All of these people had essentially no formal education. So that's something very unique about the YCAP cohort, is that there's some people who know how to read and write because they were taught by their older siblings, or they essentially had a little bit of home education, but they never had formal schooling. And they're almost, most of them are illiterate in the YCAP cohort, but there are a group of people who have literacy skills. They're not like the top readers, but they have top literacy skills. And what Miguel and Gloria Felix found was that literacy, just independent from educational exposure, schooling, protected people against incident Alzheimer's disease. But when you look at the cognitive test scores over time, this is what you see. There is no difference in the slope here whatsoever. You can see the illiterate folks are starting at a lower intercept, and the literate folks are starting at a higher intercept, but there's like no slope difference. And so we always have to kind of keep this diagnostic threshold in mind. It doesn't really matter in our hands whether it's based on just cognition or whether it's based on cognition and function and an adjudicated consensus conference. We do have these issues of diagnostic threshold that makes it so that people who start off lower have a lower intercept, they meet that threshold sooner. And that will affect the incidence rates. More behind-the-scenes drama with diagnostic categories. While adults with mild cognitive impairment are certainly at higher risk for developing dementia, not all of them that are diagnosed with MCI progress to dementia. So this study used YCAP data and showed that almost half of the individuals with incident MCI in YCAP were classified as cognitively normal at follow-up, which was about 2.5 years later. We did find that about 13% progressed to dementia and 30% stayed at MCI. And multiple domain MCI was less likely to revert back to normal. But this is sort of the messy inner workings of the diagnoses that we have when we're in the community. When we're in the community, we see a lot of fluctuation. So we just reviewed the challenge at hand. I discussed who to study, in my humble opinion, and also what outcomes we might measure and what we need to watch out for with those outcomes. And now I'm going to dive into points on our life course model, working from the right hand of that life course model, which is downstream, all the way left, which is upstream in that model, to identify meaningful social and structural risk and resilience factors for Alzheimer's disease. And I'm going to start with some compelling evidence that accelerated aging contributes to inequalities in brain and cognition among older adults. This first study used a white matter hyperintensity program that Adam Brickman has pioneered in the YCAP and offspring studies. And Indira Turney examined age effects on white matter hyperintensities in both YCAP, the parent cohort, and offspring cohorts. So in all these analyses, for the people who are related, who did MRI, we are adjusting for that. So you don't have to worry about that in this study. But you can see in the white and Latinx participants on the left and right sides, the red, pink, and blue, there's an inflection point in later age when the increase in white matter hyperintensity volume appears to accelerate. But among Black adults in the middle, you see that this acceleration is already apparent in middle age. So Indira interpreted these findings as evidence of so-called weathering or accelerated brain aging, which is a cumulative impact of structural racism and social, physical, economic adversities that are faced by minoritized people and embodied biologically. She also looked at cortical thickness and essentially found the same thing, the lack of that inflection point in the Black offspring and white cap participants. This is Justina Avila-Rieger's paper where she looked at DNA methylation in the health and retirement study and how that related to memory level and memory slope over time. She found that overall accelerated biological aging was associated with lower memory performance in the health and retirement study, but this was especially the case for white men and white women. Many of the relationships between biological aging indicators, these biological clocks, and memory performance were the strongest for Latinx women, but there weren't enough of them in HRS, this biological cohort, to have statistical precision. Black women consistently demonstrated the weakest associations between DNA methylation and memory trajectories. We've just now talked about biological aging. Now we're going to move left again on our life course model and talk about schooling, about what we know about we do know that educational attainment is consistently associated with lower risk of ADRD. Is it causal? Is it limited to attainment? Are there similar returns across groups? This is a picture of a school in the Dominican Republic in the 1940s on the left, and a school, a one-room, all-black schoolroom in Alabama in the 1930s. And many of our participants went to school in those places, in the YCAP study in northern Manhattan. Because we had recruited people over 3 waves in YCAP, it made it possible to study cohort or period effects in ADRD. And in 2019, we had followed people long enough that we could match birth cohorts on age in the study. So all these people in this figure here are the same age when we're getting data from them. But they are from different birth cohorts. And what Jet Vonk found, who was a postdoc at the time in our group, found a benefit of being born later, both with respect to incident Alzheimer's disease, but also, as shown in this slide, people born later had a slower memory decline over time. And the secular trends for rate of change were robust in all 3 ethnic groups, Black, white, and Latinx. So what Jet did find was that the benefit of being born later was explained by higher childhood or family SES and higher educational attainment. I mean, these slopes were overlapping after accounting for those 2 factors. Because those secular trends in educational attainment were due to policy changes requiring additional years of school, I think this adds to the list of evidence that there's a causal link between educational attainment and Alzheimer's disease. Policy changes across the nation are natural experiments that can be offer natural experiments to establish these causal links. And we looked up information about length of school year, student-teacher ratio, and percent attendance in administrative records from 1911 all the way to 1960. And in the regards cohort, where Black people and people in the stroke belt are oversampled, we were able to include almost 20,000 people and found that higher investment within these administrative records in elementary schools were associated with lower risk of cognitive impairment later in life. That effect was strongest in white people, especially white women, but weakest in Black people, especially Black men. This I'm going to turn to Project Talent, which is one example of these educational cohorts that are now being leveraged thanks to NIA funding to study later life cognition. And grab some water. So Project Talent started in 1960 with 377,000 9th to 12th graders who were from 1,200 schools around the country that were randomly sampled. And every student in each school that was selected was a participant in 2 days of testing. And that included personality, knowledge, and cognitive ability data and demographic questions. And then the Project Talent Aging Study, 58 years later, tracked 22,000 people who were a part of that initial study in 1960. And so this is a school-based cohort. And what Nika Seblova found and was able to publish last year, she first developed indicators of high school quality that were reported by principals at the time of schooling, and predicted cognitive function, which was done over the phone, 58 years later. And so those school quality indicators were teacher salary, school size, number of teachers with graduate training, as an example. What Nika found was that attending schools with higher number of teachers with graduate training was the clearest predictor of later life cognition. And school quality especially mattered for language abilities as they were measured by Project Talent Aging Study. She also found that teacher salary and school size had a larger impact among women in Project Talent as opposed to men. Black respondents were disproportionately exposed to low-quality high schools, as we, I don't think that's new knowledge, but there were no interactions. So, in other words, the main effect of these school quality factors was the same across racial and ethnic groups. But what this means, because there's a higher sort of prevalence of people who in the Black population who are being exposed to these lower school quality conditions, that increased investment in schools, especially those that serve Black children, could be a very powerful strategy to improve later life cognitive health among older adults in the U.S. Finally, to end up, I'm going to talk about systemic, institutional, and interpersonal racism as a structural determinant of cognitive function. So just to quickly bring you through, this is in the Offspring study, right? So this is not the white cap parents. This is the mean age 55 people, where we gave a measure, a classic measure of exposure to discrimination, including daily discrimination. Basically what this chart shows is that among non-Hispanic Black participants in the Offspring study, who are in orange here, they had the highest mean exposure to daily racism compared to Latinx in purple and white people in gray. And on average, Black participants experienced interpersonal discrimination at least once every week. We also looked at reports of occurrence and frequency on the major discrimination scale to measure institutional racism. And the second bar chart that I just pulled up shows that non-Hispanic Black people experienced almost 6 civil rights violations on average in their lifetime. We also knew that racism is maintained by policies and other structural factors, and so to represent this, we actually had the parents' residential segregation, which represents the conditions under which these offspring lived as children during childhood, we did that to study institutional disinvestments that reinforce racial inequalities. At least half of the Black and Latinx participants lived in segregated neighborhoods during childhood, and in contrast, that was true of only about 8% of the non-Hispanic white participants. So we used linear regression, and we adjusted for age and education, years of schooling, to examine the relationships between interpersonal racism and memory. This plot shows beta estimates and confidence intervals for this relationship in the overall sample and also for each of the racial and ethnic groups. And then the yellow dot at the end is showing the relationship of age to memory for comparison for you. We found reliable relationships between daily experiences of racism and memory in the whole sample. And this corresponds to about 3 years of chronological age and was driven by the non-Hispanic Black participants. I want to mention that actually Michelle Mielke brought it to my attention because I don't read every journal article, but she did a really cool study in the Alzheimer's Association Journal recently, where she looked at a black cohort that's been followed for many, many years and used many different blood draws and looking at plasma amyloid levels. And she found a relationship in that black cohort between everyday discrimination and levels of plasma amyloid in that sample. So check that one out. I'm still processing it myself. And hope to take a look at it and see if it is replicated. This plot has the same, in our cohort, this plot has the same layout. This time we're showing the relationship of institutional racism with delayed memory. There was a reliable relationship between institutional racism and memory scores among non-Hispanic black participants such that each reported civil rights violation corresponded to the effect of about 4.5 years of age on memory. And then finally, participants who lived in more racially and ethnically segregated neighborhoods when they grew up had lower delayed memory scores, but this was not reliable statistically in most of the sample, except for the entire sample. You can see how segregated our sample is by that. So in sum, I have gone over the considerations for who to study, what to measure, and the ways that we have tried to tackle some of these structural and social factors. I think that some challenges that we in the field are facing are about the commitment to community engagement, how much it takes, how long it takes, how much money it costs. I am conflicted about our finding of returns to schooling, differential returns to schooling across racialized groups, because I think this has implications for interventions which could widen disparities if they are not targeted correctly. We are worried about the spatial scale for area level exposures and therefore sort of the spatial scale in which interventions might impact cognition and cognitive aging. We need to work on incorporating more resilient strategies into our work and not relying on deficit models. Middle-age, midlife cohorts need to happen because disparities narrow with age. We still have some challenges for cognitive measure development, I think, in multiple domains. And I think there's a conflict between, the cost of oversampling when you do a study and this, challenge of intersectionality where, not only do you need to have enough people to look at racial and ethnic groups, but you really need to characterize black men and black women as separate groups, Latinx women and Latinx men, and so on as separate groups. So I think what I've talked about is structural policies that narrow brain health disparities for us to avoid this idea of healthism, which was really sort of coined by this guy named Crawford and then recently brought up in a nice commentary by Tim Daly, which is essentially blaming people. Healthism is blaming people and putting the onus on them for improving their situation in life. And instead, if we can focus on structural policies, investment in teachers and schools that serve minoritized children, housing investments, reducing neighborhood inequalities. I know that's not easy to do, but I've listed some of those factors there. There is some new evidence from South Africa that cash transfers benefit later life health, and that will be coming out soon. And I'm very interested in this idea of baby bonds as a cash, a way of improving income and security, reducing precarity. Universal basic income. We have a study from people at Berkeley showing that food stamps, as they got rolled out county by county, then relate to lower risk of diabetes later in life. And I think we should do that same study with cognition. We need to reform police funding, demilitarize, and reinvest that in community safety programs because incarceration and policing is a stressor related, and people are working on how to show that it's related to cognition. It is related to other health and wellness outcomes. Lower eligibility age for Medicare. And then finally, and I think NIA is doing a wonderful job of this, which is to train anti-racist and diverse research and healthcare workforce. Thank you.
We do have a couple questions online, but I would love anyone in here to please go to the microphone. I'll repeat the CME code, 50124. 50124. Dr. Gottesman.
Hi, thank you, Jen, for that wonderful talk. I was just wondering if you could sort of speculate on what you think the mechanisms are linking the social and structural determinants with the biological changes that you described. I know there's been some work describing sort of increased inflammatory markers that perhaps that might mechanistically link the two. I'm just curious about your thoughts.
Right. Well, I think that, we're working on finding that. We're working on making those connections. Part of it is, recognizing that, some of these exposures, it's better to study them when they're happening, right? So those school-based cohorts or those adolescent cohorts, tracking people over time, where we have longitudinal biomarkers that can look at inflammation, but also, those social and structural factors. I mean, income seems to have a very strong effect on memory slope over time, but not so much on intercept. Whereas, like childhood SES has a major impact on intercept, but not so much on slope. So, I think occupation is one likely mechanism, family formation and, the stresses that go along with, with supporting a family, that can go along with supporting a family if you are living in poverty are another possible, mechanism. So, if your question is what are the social and structural drivers of those, of those biological factors, I think that, we're not there yet. But, I think these longitudinal studies that are now emerging, that have longitudinal biomarker collection are gonna help. Yeah.
Okay, maybe a question from online then. Is the rise in the rates of dementia in low and middle income countries directly related to the rise of life expectancy, or are other factors involved? I ask because GDP is not a perfect predictor of life expectancy.
Yeah, I think that it's both life expectancy and also the aging of the population in general. Just
cohort?
The sort of the cohort, right? So there are just more older people. That the balance between older people and younger people is shifting towards older people. But yeah, life expectancy, since age is the #1 risk factor, that's what's happening.
Mm-hmm. Okay. It's an NIH question here. Your work suggests that education in general is protective. Have you seen any correlation with specific types of education, such as STEM versus non-STEM?
So one of the studies I'm working with now, high school and beyond, one of their key findings is that STEM courses, that when high school students were able to took STEM courses themselves, and obviously they took them because they were available, at the school. They correlate with sort of the human capital outcomes, earnings, occupational status, and the things that economists usually measure. That turns out, as we're sort of diving into the data, not to be as strong a predictor of cognition as one would think through those mechanisms of better occupation, higher earnings. Instead, the two things in the high school and beyond cohort that are really seem to be driving, and I hope maybe next time I come and talk, I'll be able to show you all those data, which is, family SES really, really drives where you go to school. And I mean, it is extremely, strongly related to the quality of school that you go to. So once you sort of adjust in your models of family SES, the effects of school, of those school quality variables basically flatten. And that all leads to attainment. So attainment is really the thing that the better you do in school, the higher quality school that you get, you have a higher attainment. And that credential sort of then it goes a long way throughout life. I think it's a very powerful thing. And so while, years ago I started out kind of trying to ask, well, it's not just attainment, it's about quality, but that quality then leads to the attainment. And that attainment is the thing, the credential and that experience is the thing that cognitively, I think, has the most effect in cohorts like high school and beyond. That went to high school in 1980.
Okay. So while you didn't find mean differences in blood biomarkers by race in YCAP,
I did not.
Right. While you did not do that,
Okay.
There was a much wider range of many of them in the Black and Latinx groups compared to whites. Can you speak to why that might be?
Because it's really hard to find white people in the offspring study. So, I mean, it's really just a matter of sample size. The families in YCAP who are Black and Latinx have more children, and the white people, at least in the beginning, before COVID, when we were really collecting a lot of blood, and now it's got back online, obviously, but we sent those samples out during COVID. And so the children of the white participants in YCAP are most likely to have moved away out of the area. And so they were harder to find. And so we're on our way to get their blood now. But that's the reason why you see that sort of variability issue. It's a sample size issue.
Jennifer, wonderful presentation. And, there's so many questions that come to mind. But one of them is, so we see that, especially over the last 2 decades, there is a widening of the difference between the poor and the rich. I mean, it's very worrisome that so many more people are under the threshold of poverty, and that there are so many more people that are not on the threshold of poverty, but still don't make it. And so, based on what you see in your study, you think that the rise on the risk of dementia, that will be due to this increase in stress, increase in access to education, increase in reduced access of health care, and I think that's something that we don't talk about, but it's likely that will have health consequence in the population.
I think there are many factors working together, and that's why it's so important for us to be able to measure all these risk factors with the resilience factors. So one of the things that happened with the YCAP study that I didn't mention is that in the later born cohort, there was a much higher prevalence of diabetes and hypertension than in the earlier born cohort. But the effect of hypertension and diabetes sort of in explaining those cohort differences was nothing. And also just in explaining the risk of developing dementia was less so in the later born cohort because they're being treated more effectively, right? So did a doctor ever tell you have hypertension? Does a doctor ever tell you have diabetes? That's essentially what those questions are based on, in addition to whether they're taking medications. And many more people were being effectively treated in the later born cohorts than in the earlier born cohorts. So even though the prevalence is much higher in the later born cohorts, the treatment is better. So I mean, I'm not saying let's not worry about it. I'm saying I agree with you that the one thing that we need to I think would be very interesting to explore is whether the disparities are more sensitive to absolute gaps or absolute disparities, absolute inequalities, or whether they are sensitive to sort of everyone's going up, but those inequalities are remaining those gaps are remaining the same. And I think, cohort data like that collected in the HRS will be able to help us understand that.
Yeah, and again, a fantastic talk. In terms of your guidance for the kind of research we can do toward the future, big discrepancy, as you're pointing out, between community-based studies and clinic studies. For a time, a part of the explanation was the kinds of data we needed to collect could only be done in the clinic. But to ask, now that we have blood biomarkers, digital biomarkers, so many more creative ways to monitor biologic and behavioral functions, that gap ought to be closed. We ought to be able to do better, don't you think, in the population studies than we've been able to do so far?
Well, I think part of that is going to take a retooling of the investigators that my colleagues and me. We need to retool ourselves to be better prepared for those community-based studies and to roll out biological measures in those community studies. It's not trivial, and it is actually expensive, Richard, to do, just to let you know. I think you're absolutely right that I feel very hopeful about it and very excited about it. But I think there needs to be a reckoning, essentially, with those studies that, over time haven't really, been able to diversify, and a retooling of the teams that are associated with them, because I think I think some very exciting science can happen when we merge those sort of population-based studies with population biomarker technology.
No more questions or comments? Just to thank you. This is just a tour de force and demonstrating to us how one can join community-based social determinants, biological determinants, their convergence, and the inspiration it provides to all of us. Florence Mahoney would be proud. Thank you so much.
Thank you.